and we will connect to them.
Maybe before connection, we can invite our panelists.
Yeah. Sorry.
I would like to invite our panelists to stage. İsmail Bolat, Asil İzci, Aydin Nadir, Zeki Doğan, Bektaş Bayani, and Zekeriya Doğan. Are they here?
Tamam. Evet.
Bir kişi mi bu?
Yok.
İki.
Burayı belki çekmenizi isteyebilirler arkadaşlar. Kontrast kaydı.
Yansıyor mu? Tamam.
Yansıyor.
Evet. Ersan et Mustafa, hello. My name is Bülent Altunkeser Ersan.
Hello.
Can you introduce your team and can you give knowledge about the patient and angiogram?
Hello everyone from Flora Medical Hospital. We together Dr. Mustafa and nurse Eray and Berat. Can you please presentation the case?
Hello to everyone. I'm Dr. Mohammed from Florida Medical Park Hospital. I will present you this case. We have a patient, 34-old male patient diagnosed with Buerger disease since 2012, and he has smoking history of 8-pack a year, which was quite like 2 months ago. He was suffering of claudication in both legs, especially in left leg. He was medicated by acylostazole, atorvastatin, and aspirin. His ECG was normal, and echocardiogram was normal also. Myocardial perfusion scan was normal. There is any abnormality in lab values. And lower extremity CT angiography revealed both superficial femoral artery in mid-segment, total occlusion, and peripheral angiography was revealed a left superficial femoral artery, 100% occlusion at the origin, and popliteal artery 100 occlusion, and anterior tibial artery, peroneal artery, and posterior tibial artery 100% occlusion, total occlusion at the region, and the distal is filling at the via collateral vessels, and we have here the angiography imaging. And thank you so much for the presentation.
Same to you.
Can you hear me?
Yes.
Here you can see that there is a flash occlusion of the SFA. It's a long lesion. The blood flow is restored at just before the tibioperoneal trunk. Anterior tibial artery is totally occluded, and posterior tibial artery is intact. Because of the flash occlusion, we will go from retrogrades. Now we are trying to, with ultrasound, access to the posterior tibial artery. Do you have any recommendations from the panel, from the audience?
Yes, is there any comment from panel?
Şeyden opak verelim mi abi?
Ersan abi, can you hear us? I think there isn't any question or comment from the audience or panel. But I wonder that this patient is a very young patient. He is 34 years old, and 2012, I think he was diagnosed
for Buerger disease.
Is there any vasculitis or anything other problem for this peripheric artery disease?
Sorry, I couldn't hear your questions.
Perfect. As you can see in angiography, we have ambiguous SFA CTO and Buerger disease. What is your opinion, this patient? Because there is a stump CTO, antegrade wire advancement, it is not possible because retrograde transpedal access can be processed. Firstly, we can try posterior tibial artery puncture guided Doppler ultrasound.
Yes.
Now we are at this stage with ultrasound. Can you see ultrasound?
Yeah.
With ultrasound guidance, we are trying to puncture posterior tibial artery.
As you can see, penetration.
Yes.
Doğru gözüküyorsun.
Daha derinde. Evet, tamam. Ağrın mı oldu? Tamam. Biraz daha şöyle.
Do you start to punction soon?
We are trying to puncture now with ultrasound guidance.
It is not. If it is not possible, we can try contrast-guided posterior artery puncture. What is your opinion on antegrade approach?
You are senior cardiologist in this field. We know you.
Şurada çok güzel.
But if your retrograde axis fail, then you can try the antegrade option. At least from the three another view. Anterior posterior, left anterior posterior, right, and left anterior posterior, lateral.
Evet. Yine şeyden girmiş. Perfect.
Genç. Şunu bakalım şeye.
Görelim.
It's okay.
We did contrast-guided puncture posterior tibial artery. As you can see, angiography, no.
Yeah, we see.
Yes.
Move on.
We see.
We insert posterior tibial artery 6 French radial sheet. Yes, and then 0.18 mikrokateter
Şu
var mı?
uzak olsun.
0.18
Katedrali yanlışlıkla şey yapmayalım.
Tamam. We can try
yanlışlıkla katedrali sıkmayalım yani.
18 microcatheter and Gladius 13 wire. Retrogradely is advanced to SFA
Heparin alın.
That's reasonable.
Kaç 10.000 yapalım mı?
Heparin yapmıştık
Yok,
yukarıdan.
yapılmadı değil mi?
Ha, heparin yukarıdan
Heparin yapılmadı değil mi
yapmıştın
arkadaş? You have heparin?
No. Yapmadık, yapalım, tamam yapalım. Buradan bir kontrast verebilirsiniz
Kaç
şey olarak.
10.000. It's all 10,000.
Küçük kontrast verebilirim istersen.
Şunu şey yapayım abi.
İyi gidiyor. Topuğundan girdik, öyle açacağız ama, tamam mı?
You are inserting sheet.
Yes, we inserted the five French radial sheets.
Okay.
Tamam. Şantros, mikrokateterya.
Nitrat, tamam opak.
Tamam. Gladys Fransız. We did Chantros 18 microcatheter from Chammay and Gladius 18 wire.
Yes.
Opak.
Bir kontrast yok mu? Kontrast bir görelim. Küçük bir görebilir miyiz? Küçük bir trolüven kontrolü yapalım.
Aşağıya görebilir misin?
Ayağı görebilir misin?
Zaten şey.
Zaten yukarıya takip edin. Gel. Okay, çok. Tamam, güzel.
Good.
Ersan abi, can I ask a question? We know you are a very dedicated and expert operator for below the knee lesions. When you puncture from transpedal region, after sheath insertion, you give any nitrous for preventing the spasm?
Yes. Correctly.
Yes, like radial sheet insertion.
Görelim yukarıya doğru. Mikro gelsin, tel kalsın, mikro gelsin. Teli sabit tutalım, mikro
Teli
gelsin.
sabit.
Tel gelmesin.
Sabit. Abi, geldi mikrona bir saniye.
Bekle. Ucunu düzeltelim. Burası tutar mıydı?
Buradan şey abi. Şuradan sonrası total abi.
Peki bekle.
Antegrattan da. I will give antegrat injection. Yes, it's coming.
Yeah.
Yes,
Yes.
we are here.
Trolüven, yeah.
Yeah, we are at this distal cap.
Yes.
Bekle. Dümeni biraz düzeltelim.
Excellent.
Biraz küçültelim. Belki burada büyük bir şeye geçmemiz gerekebilir. 35 şeyi büyütmemiz gerekebilir. Okey, büyütelim. Tel kalsın. Mikroyu çıkalım.
Skop yani.
We try 35 microcatheter and 35 woodrunner wire to gain in advancement
0.35 mikrokateter.
in pompilital segmente. Tamam. This is Berger disease, therefore the vessel patency at bed 6 months. In this patient, it is important thing. I think deep profunda artery is protect.
Yes, of course.
Sabitler.
Teli değiştirelim şimdi. 35
Teli alır mısın?
Aha. 35 Roadrunner.
0.35 Roadrunner.
Is it Xiaomi microcatheter, right?
This is 0.35 microcatheter now. The previous one, Xiaomi 0.18 microcatheter.
Okay.
Buna mı Xiaomi'nin?
This is The previous one was Canlı.
Tamam.
Now we have
018 or 040?
this is 035 and we are now having Roadrunner 035.
Okay.
Gel. Evet, loop'unu bir görelim. Küçük biraz loop yapsın. Küçük loop yapalım. Biraz
Ersan, did you change the wire?
Yes, this is Roadrunner 035.
35 wire Roadrunner to gain in advancement.
Ayak orada bir biraz daha yaklaşık.
The wire of tip loop should not be
Gidiyorum.
big than vessel size.
Roadrunner is really excellent guide wire, but in this stage,
Geçtik herhalde.
Bekle.
Oradan bakalım,
in this
geçmiş
stage,
olabiliriz. O geçtiği
you
için.
selected loop guide wire instead of stiff one.
Geçtiğimiz için miydi?
Bak, bekle, bu yok. Alabiliriz. One stop, o da var. Tamam. Ben şimdi teli şey yapacağım. Teli şeyin içine sokacağım da lümen kontrolüm teli çıkalım.
Bir
Yok,
şey
buradan
yapalım
değil.
opakla.
Yok, buradan tersten veririz. Teli çıksa.
Deli alabiliriz.
We will check through
If
lümen
we are in
control.
the
Yes.
moment.
I think you crossed to occlusion.
Yes, it's bleeding.
Yes, yes.
Yes. Veriyorum.
Evet.
Tamam.
Yeah.
Yes, we are in the true limon.
Through lümen, but we will try externalization retrograde wire antegrade guiding catheter. Evet.
Yes.
Şuradan bir 0.18 tel alalım, bunun içine girelim belki. 0.18
0.18.
Canlı olur, fark etmez yani.
You need a floppy guide wire, I think.
Ne aldık ne?
Tamam, 0.18 uzun değil mi o?
Biraz
Ersan,
açabilirim.
I think would you like to try tipping technique? That's right.
Evet.
Ya, tipin.
It's 018 wire.
Gönder. Güzel.
What's your guide wire now?
018
18 Canlı. Bekle, ben
Biraz
Is
aşağıya.
it floppy, right?
Hidrofilik floppy. Ya.
Hydrophilic. Okay.
Biraz
Haydi
geri mi
bir
alsak
floppy.
abi mikroyu?
Ha?
Mikroyu geri alıp. Çok azıcık.
Ersan, maybe it will be useful if you get right corner catheter.
Yes.
Ya,
If we didn't
it can be.
manage like this. Biraz daha açayım arttırma.
Yo, ben biraz uzun açısını artırıp bir mikroyu biraz daha dayayalım
Yani.
şöyle.
Maybe you can rotate anti-grade.
Yes.
Biraz daha
Yes.
koaksiyel hale getirelim.
Yes.
Şimdi de. Öyle, ha. Ucuna açı var biraz
Biraz
daha.
daha şunun arkası değmesin. Hemen düşmesin.
We can be retrogradely in advancement the balloon, but spasm can be. Therefore, anti-grade approach is best option.
Yes, absolutely.
Biraz katını geri al istersen, loop'u daha şeyden alırsa.
Olmadı. 014 hidrofilik şey floppy tarzı. Belki.
18 girer buraya, rahat girer. Evet, tamam. Yok. Tamam, harikasın. Çok perfect, çok güzel. Görelim, gördüm. Gel dön yukarı. Aşağı kası göster bize.
Congratulations.
Bir tane bekle. Alt F sağ guiding ver bize şimdi. Alt F sağ. Ha yok, verme. Alt sağ guiding gerek yok.
Tamam,
verme. Sen gönder, çıkarırız buradan. Gönder. Gerek yok, çıkar. Gönder. Gönder. Bir tane şey alalım sadece. Biraz daha gönder. Gönder. Tamam, okey. Tamam, harika.
Ha, o da olur ya da.
Nasıl? Ha, onu ver.
Dilatatör.
O daha
rahat olur.
Buradan girmeyebilir ama sen girdin, harika. Daha rahat olur.
Ucu biraz yamulmuş. Keselim mi?
Yok, sokarız. Biraz daha gönder, çıkarsa atıyor. Tamam. Aynen, iyi olur.
Kasar mı ya da?
Yok, sokarız ya.
Now we have externalized our guide wire from the right femoral.
Evet. Çekiyorum ben. Çek, mikroyu çek alt geriye.
Şu şiti tutar mısın?
Sen, bu bende, sen çek ama. Burası bende zaten. Okay. Al. Tamam. Okey, tamamdır. Şuraya bir tane şey koy. We do wire externalization from transpedal to femoral access.
Şunu şey yapabiliriz.
The system
Var mı paragraf?
can be change integrate. We advance integrate the process. Bir balon alalım şimdi. Pop
4 5
Pop bir tane SF'ye
4 ile başlayalım.
5 ile alalım. 5 ile alalım. Aha.
We'll have a 5 mm balloon for predilatation.
Tamam, olur 500'e.
5 and 115. Şöyle yapalım.
Arkadaşlar şu suyu değiştirelim mi? Kan olmuş da ya.
Tamam, oraya çok şey. Tamam, nitrat gerekirse şu an şey.
Gayet iyi gidiyor, tamam mı? İyi gidiyor, çok iyi gidiyor.
Ya, alsın.
Pardon. Bunun sonrası kolay zaten artık şimdi.
İnşallah.
Hadi 5'lik balonumuzu alalım. İstersen o zor olacaksa ucunu kes bir tane makasla. Yani getir götür.
Makas var.
Steril makas.
Geçer bundan da. Yani.
Tamam, geçersen gerek yok. Gerek yok, gönder. Gönder, tamam.
Yıkadım mı hocam? Yıkadınız mı arkanı?
Bunu yıkadım.
Tamamdır.
Bizdeler mi? Diğer tarafa mı geçtiler?
Are you with us? Or?
Yeah, we are watching you.
Okay, we are now advancing the balloon.
Which diameter and length?
5 and 115. 150 millimeters. 5 to. Geçti.
Gel, tutalım. Ya, şeyi görelim mi arkadaşlar? Aşağıdan başlayalım. Gel, daha aşağıdan.
Takip edin. Just follow. We will start from the distally.
Gel aşağı gel. Popitale kadar şuradan 5 ile başlayalım. Sonra aşağı yaparız, görürüz. Evet, burada. Yukarıda.
Biraz yukarı. Yes. Okay.
Biraz ağır olacak, oldu mu? Endişe etme. Beklenen bir şey.
Okay.
Şey. Sonra Trulli ben yani.
Evet.
Balloon inflation is show in the Trulli man.
Normal şey neydi? Nominal basınç 8 mi?
Sonra yine.
Okay. Yeah, it's
Biliyorsun
6.
biraz. Bir dakika. Bu predilatasyon balonlar zaten. Kontrast şey sıvı değil mi?
O nitrat da olabilir abi.
Öyle mi? O
Şu
zaman
sıvı vereyim ben sana.
Balondan sonra nitro yapalım bir görelim. Bu bölgeye, alt bölgeye belki bir 3,5 ya da 4 balon gerekebilir şeye. Bir altına.
Tabii yaparım ben.
İnelim, bu predilatasyon gerekirse buraya. Belki dep yapabiliriz.
Just
Yukarı.
shove. Okay, current.
Al yukarı al. Alt marka burada.
Okay.
Tamam. Şu. Biraz ağrın olabilir. Evet, biraz olacak. Sabret. Bir dakika kadar bekleyelim.
Ersan, how much minutes do you inflate the balloon?
1 minute.
At least 1 minute, but
Without drug eluting. Drug eluting balloon with at 3 months, 3 minutes.
Yes, yes.
şeyde dur.
İnelim.
I inflate all type balloons for 3 minutes, regardless of drug eluting balloon.
Biraz ağır olacak, haklısın. Ama aslında 5 çapında çok büyük tabii ya.
Yavaş yavaş. Normalde de çok. Önce 6'ya çıktım.
The patient is feeling pain at the balloon inflation. İnelim. Masa sabit kalsın arkadaşlar.
The new literature suggests stage balloon angioplasty
Yukarı görüyorum
in
arkadaşlar.
such
Şimdi yukarı görüyorum.
cases
Biraz daha görüyorum. Az
from
yukarı. Bir şey güzel.
small one to big one. For example, 2, then 3, then 4.
İsterseniz şey yapalım. Bu balonu gönderelim aşağıya kadar. Sistemi anti-agala çevirelim tamamen. Düze çevirelim şöyle. Hem de şey yaparız. Tip enjection yaparız diz altına.
Oldu.
Ya da dursun fark etmez. Ha.
Dur. Balon yetecekse.
İnelim. İnelim tamam. Diz, poplitalin distal kısmı biraz daha ince gözüküyor. Posterior tibiale doğru. Oraya bir 4 balonumuz var.
We'll have now 4 balloon
4.
for the distal, for popliteal artery.
Yes.
Çıkalım istersen. Balonu alırız. Çek al direkt. 450 tamam olur. Alalım açalım. Sonra da nitro hazırlayalım. 400 nitro hazırlayalım.
Bak şey yapalım mı film?
Verme.
Mikrofonda ses isteyelim arkadaşlar. Ahmet Hoca'nın mikrofonuna.
Yeah. I think the operators perform a great job. We know that the Burger disease is very different than the atherosclerotic disease. The vessel is full of the thrombotic tissue and also the fibrotic tissue. And in such case, we usually expect a distal embolization after the plain balloon dilatation. So, Dr. Ersan, in your clinical practice, you usually use the distal filter for the protection or not?
No, not a distal protection device in my practice. Okay, aşağı görüyor musun?
Aşağı görüyor.
Aşağı.
Can you take angiogram?
Yok yok. Evet şöyle. Evet.
Şöyle bir saniye. After the balloon dilatation, we'll have another image.
Yeah, after the balloon dilatation, and then
You can. Okay.
Aşağısı zor. Evet.
Ersan, what is the size of this balloon? It's still 5?
4 and 150.
Bir DSA görüntüsünü oynatır mısın? O bölgede bir şey payımız var mıydı? DSA dizaltı vardı ya bir tane. Onu oynatır mısın bize? DSA, yok almayacağız. DSA görüntüsü var ya onu izleyeceğiz.
The last, the previous one. The popliteal region.
Preview'la. Bir öncesi preview'la.
This one. Şuraya kadar inmek lazım.
Var lan payımız varmış. Şurası şey işte. Ona sonra bakalım olmazsa tamam. Dizi altına ayrı değerlendirelim olmazsa tamam. Tabii inelim. Bir nitro sonrası bir kontrol yapalım. I usually nitrate routinely 4,000 milligram. Tamam ben bir 400 mikrogram falan mı?
Şöyle. O da mı?
Tamam 400. Sulandırılmış 400 değil mi? Tamam. Yanlış olmasın.
Ersan'cığım, can you take a angiogram?
Yes, after nitrate.
Connect to the other.
Yes, okay.
Tamam, bir yukarıdan gelin bir kontrol anjiyosu bir öğrenelim ne olduğunu. En başa gelin isterseniz. Yukarı evet. Tamam, şuradan bir kayıt alalım isterseniz hazırsa.
DSA'da hocam bir de.
Ha, evet, pardon.
Yok,
çok
normal. We will takip edelim.
Ha. Hazır mı? Evet. Tamam. Distal biraz çalışacağız distale. Distal çok iyi değil hala. Oraya bir DSA mı girelim distale?
Şu bölgeye bir DSA ile.
Evet şu distale DSA girelim.
Ersan abi, the other cat lab is ready and if it is okay, we want to connect there and we will come back soon, okay?
Okay, we will go on for the distal SFA.
Az yukarı, az daha yukarı, az yukarı. Az daha yukarı. Yukarı. Hah, okey tamam.
Yes, let them continue to the operation and we will connect to the other salon. Hi Yılmaz and Serhan. Can you introduce your operation team and
okay, now we are together with Serhan
knowledge about this patient
and Ozan and our team Fatih and Bekir in Istanbul Institute Cardiology Department. My old town, I think we can say that. Now our friends will present the case.
Dr. Heja will present the case now.
Okay. Hello again. I'm Dr. Heja. Welcome back to CAT type of Istanbul University Cerrahpaşa Institute of Cardiology. We have 4 cases for you today. And let's start final case. Our patient is 80 years old male. He has a claudication caused by walking 100 meters for 2 years. When we questioned the patient, we learned that he has hypertension, peripheral arterial disease. 25 years ago, he has a left femoral popliteal artery bypass surgery. He is using acetylsalicylic acid, clopidogrel, and statin. These laboratory and echo findings were normal. Because of the remarkable symptoms, he has several lesions. Left superficial femoral artery is totally occluded from the distal end. Our final decision is revascularization of left SFA artery. Thank you for your listening.
Okay.
Listen. Now you see the case, that's a hard case, as you imagine. The patient has fempop bypass surgery, as he thought, but we don't have the report of the operation. And he has collocation in his left leg. There is no wound, but distal SFA is occluded abruptly. Now we have integrate approach today, because if we will be able to cross the distal SFA, then we will have difficulty in case of retrograde approach from the right side in respect to tortuosity of the other side and the length of the available products, as you know. So can you show the first image? Okay. No. İlk baştan. Burası. Now, in integrate puncture of the femoral, common femoral artery, first we cross the profunda, and by roadmap, because I was sure about the common femoral site, it was the location of the common femoral artery, not the SFA or profunda. We have introduced our sheet and have a roadmap. We can see the profund and the SFA in the and with date of that roadmap, we had another 0.05 hydrophilic wire and crossed to the SFA and then continue in the integrate fashion. The next plan, please. Bir sonraki. Baştan buraya şaş oynasın.
Gelecek şimdi.
Distal SFA is occluded. There is no main branch. This below the knee is just supplied with the collaterals.
Yes.
Before procedure, we have checked the distal leg with ultrasound available here. Serhan and me together with found look at whether we have a retrograde approach or not, but we were not able to see the distal architecture in the foot. So now we will have integrate approach by chance. If we were able to cross something, then we will try to do our best. And the second, maybe with distal selective injection, we may see distal architecture better. In that case, if we fail with this ambiguous approach of integrate puncture, we may try foot retrograde puncture, maybe dorsal space or tibial posterior if we can see there. Now we have our five French vertebral catheter here, and we try to cross that ambiguous gap, and with Albert 018 we have some progress, but we are not sure about the distal true lumen. So I have introduced a small balloon with the aim of microcatheter 0.100 balloon we have in it, and then we have injection through that balloon. The next image. In that case, we are not sure about whether we are extravascular or there's a thrombotic long visualization of the architecture. We are not sure about that. If you have some suggestions, we can continue in vivo suggestions. Thank you.
Yılmaz, which side was the operation? Right or left?
Left.
Left. You are trying in this left.
Yes.
At the same time.
The index pressure.
Are you sure of
operation
of the graft?
There is no graft. We cannot see it. If it
you
is present, it is
occluded graft. Okay.
We may be in the graft now, I think.
Whether we are in graft now, maybe we are in graft. That image may be related with occluded graft also, or occluded native artery. But I think we are whether in occluded graft and subintimal passage or extravascular. I don't know. Now I will try a hydrophilic wire, whether it will cross distally or not. I had MG now. I will try to cross that distally. If you don't any objection.
We don't have any objection. Yes, Ahmet.
Yeah. So it's very tough case. The distal landing zone is not clear. So we need a marks for the distally. So I think the bidirectional approach will be more logical, especially in the first image. There is a visualization of the anterior tibial artery, and maybe if the pedal access is problem, the function of the anterior tibial artery may give a mark, and bidirectional approach will be, I think, more useful for this case, because the popliteal artery is completely diseased, and also the trifurcation is not so good. We don't know the distal landing zone.
That is our major problem. We don't have distal landing zone and distal puncture sites. So it is the impressive part of that case. Bir aşağı göstersene biraz. Yok. Heh. Tamam. Yine bir DSA yapalım. Evet. Now we are in the, as you see, we are in the true lumen. Okay, that's a chance. That is not my.
Okay.
Okay. Bir 0.14 tel alalım da. Bir de şunu bir roadmap yapalım.
It is not chance. You are a very
skilled
operator, Yılmaz.
Roadmap yapabilir miyiz? Bir ıslak. Sıfır 14.
Biraz ucu.
Ne o? O tel ne? Yok, şu yumuşak bir tel alayım ben.
Ben de ona bakıyorum.
Normal Olur. Gladius olur. Veya normal bir floppy de olur. Yani yumuşak geçelim buraya. Yani saplanmasın.
Mr. Niyazi, do you have any suggestions in this case?
Şöyle küçük bir
Okay.
loop. Peyin ucu alayım. Peyin ucu. Yine ucunu
Mr.
alayım.
Khusro Niyazi said that Yılmaz, you are wonderful.
Thank you. Thank you.
Birden çıkalım. Botnet'te kalsın.
Tor kırılabilir miyim?
Yılmaz, can you give us conventional angiography?
İlk şeyi bir daha oynatır mısınız? Ama ilk poz.
Yok normal.
Oynat. Baştan oynat.
Vardı ya baştaki anjiyo. Evet.
Heh. Tamam. Bunu serbest oynat şimdi.
Çok bulanık.
Büyümemiz aynı değil ama değil mi?
Your
Aynı mı?
fluoroscopy is very flu.
Bakalım nereye gideceğiz.
Nereden mi giriyoruz hocam?
Bir kolateral muhtemelen bu ama.
Geriden mi girsek hocam?
Buradan retrograd dönse kolateral o da işimize yarar. Şunu balonu biraz büyütelim şimdi. Şu teli gel tutalım. Yok gelmiyor. Geri geldiler. Buradan bunu ilerleyebilirsek bunu açarız. Teli gel tutalım. Now, I am not sure whether that vessel now we are crossing is a collateral or tibialis posterior artery. I am not sure. So because of that, I try to cross retrograde to peroneal artery, but I think balloon will not cross that.
Yılmaz, can you show us conventional angiography?
Şeyden çıksana. Bir daha göster şey. Şu roadmap'ten de çıkalım. Because the tibialis artery, posterior artery is large here. As you.
Yes.
So maybe we are in a collateral artery.
Real-time angiography.
Yes, this is real-time angiography.
Yes. Just make an angiography now.
Okay.
Yılmaz, can you take an image from the level of ankle, distal part of the tibialis posterior? Because there is a feeling in the distal part of tibialis posterior.
Okay.
Can you show that?
Okay. Şimdi ayak sırtına gelelim şey. Distali gel. Orada masa kit the table was locked there because we couldn't show it. Bunu nasıl gösterirsiniz?
Biraz çekebiliriz.
Ya açıyı değiştireceksiniz.
Şöyle
veya hastayı geri çekeceğiz.
Olabilir.
You must continue to the operation.
Okay.
We have a speech in that time, and
Okay.
we have valuable guests from USA, Khusro Niyazi, and he will speak out about algorithm for the treatment of below the knee. Here you are, Mr. Niyazi.
Sorry, can you switch the screen, please? Sorry. Can we get the slides?
Sesi kısalım.
Can we get the slides?
Ses. Bir de salonun sesini kısalım.
Can you show the slides of Dr. Niyazi? No. We take the speech. Can you show slide'ları gösterir misiniz?
Slaytlara geçelim arkadaşlar. Tamam. Slaytlara geçelim. Bizim ekranımızda da slaytlara geçelim. Tamam.
Teşekkür. I think the Turkish cardiologists are the best in the world. You guys do tremendous work. So thank you very much for having me. I think the cases are more interesting than my talk. So I will try to go through very fast over here so I don't bore you folks. Let's see. So some of this I presented yesterday above the knee, and the algorithms are pretty similar. Where the algorithm is not similar, I will tell those points. So the treatment for below, first make sure there's a good clinical reason why you're intervening. I think for below the knee, your threshold for intervention should be higher. Above the knee, claudication, Rutherford-Becker class 2, sure, intervene. Below the knee, be a little concerned. And I will tell you why. Because the restenosis rate below the knee is high. So I would suggest if you have critical limb ischemia, rest pain, a wound, or gangrene, you have a strong indication to intervene. But if you just have pain in the foot, walking, tell the patient to exercise more. They will develop collateral circulation and it will help them. So the threshold for below the knee should be high. Again, as I said, I do MRA because that helps me define the vessel. Over here, I've put the antegrade because if you have disease like this over here, well, not over here, but if you have disease all the way distally around the ankle and you come contralateral, in a tall person, your equipment may not reach there. So sometimes it is better for below the knee disease, you stick antegrade. Secondly, the force that you can impart from the groin, antegrade is more than if you are contralateral and trying to push things. So over here, that's why I put antegrade. But there are times I will do contralateral if the disease is up to mid-calf. If the disease is up to mid-calf, I will come contralateral. Now, in this, also the second point is don't use 45 centimeter sheath. If you don't have SFA disease, use a 65 or a 90 centimeter long sheath, especially when you're coming contralateral. If you're going antegrade, 45 is fine. But if you're coming contralateral, you want to put your sheath as far down into the SFA or popliteal so you don't give too much contrast. And also the definition of below the knee vessels will be much easier. So I always suggest 6 French, 65 or 90. But if you are antegrade, then use a 45 centimeter. And then the rest, as explained yesterday, we use a measuring tape and rad pad to protect the radiation. An angio from the groin to the foot, again, you divide it into severe stenosis or occlusion. If you have severe stenosis occlusion, then you ask a question, is there calcification or is there not much calcification? If you have heavy calcification, then the approach is different as compared to mild. The same thing with occlusion, you ask the same question. Severe stenosis, no calcification or mild to moderate disease, I still put a distal protection device because I may be treating in the anterior tibial and I don't want any debris going downstream. I just believe in that. Plaque modification, this is a Hawk 1S. S means a smaller cutter. So I will do atherectomy of the anterior tibial or the peroneal or the posterior tibial artery. I will use a chocolate balloon at low pressures for 10-minute inflation. a little bigger than the vessel diameter. And then I will use a drug-coated balloon, 3 minute, generously longer than lesion. The problem is in the States, we don't have drug-coated balloons that are smaller than 4 millimeters. But I think in Turkey, you have available drug-coated balloons that are smaller than 4. So this becomes a problem in States. Hopefully in future, we'll get them available. And then I would, if you have severe calcification, I would go with, again, a filter. I will use shockwave. You may need to pre-dilate it because the shockwave is difficult to deliver if there's heavy calcium. Use a chocolate balloon after the shockwave, drug-coated balloon, and you're done with it. Now, if you have occlusion 100%, you have to cross it. So again, as I explained, we use a Viance catheter, which you see the picture on the left side. You can use wire escalation techniques like coronary CTOs, and then you can use quick cross angle catheters. These are very supportive catheters that you can push through the blockages, and they're pretty safe. Whatever choice wires you like, you can use those stiff wires. Do not use re-entry device because these vessels are only 2 to 3 millimeters in diameter, so the Pioneer does not work over there. Pedal access, I mean, I think cardiologists feel very comfortable because of radial access. They can stick the anterior tibial, posterior tibial. I personally don't stick peroneal, but there are people who stick peroneal. I don't stick peroneal. Make sure whenever you cross 100% occlusion, you put a small catheter, pull out the wire, inject distally 50, half and half of contrast and saline, and make sure you're intraluminal. If you are not intraluminal, no harm done. You can pull out, rewire, get into the true lumen. Dilate the tract with a 2 millimeter balloon. This is only for occlusion because you need to get your filter device distally. Get your filter device distally. Again, no calcification, you follow that route. If you have heavy calcification, you follow that route. This stent was just made available in the States in July. Is it available in Turkey, this Everlumus self-absorbable scaffold? Esprit, I think it's made by Abbott Vascular. It's not available in Turkey yet? Okay, so it probably will be coming, but in States, it just got approved in July. I just did a case before I was flying back over here to Turkey. I did a case in Atlanta. I had to fight with the hospital administration because each stent is $2,700. And since it was just approved, the hospital cath lab would not get it. But finally, we got it, and I will show you that case, a very interesting case. So heavy calcification, long lesion, more than 20 centimeters, think twice. Make sure there's a good reason. So it's gangrene or wound or rest pain. If they don't have this vessel is not going to stay open even if you open up just for claudications. It's going to shut down. Okay, let's talk about this case. And stop me anywhere if you have any questions. 65-year-old man who came to me 2 years back because he is a father-in-law of a very big cardiologist in Detroit, where I did my training. So he called me, he says, can you take care of my father-in-law? Well, that's not a good sign because if something goes wrong, I'm dead. So he went to a local Chinese healer who did cupping to help calf pain. Recently, the patient was in Arizona visiting his daughter, started experiencing more calf discomfort, especially during hiking. Went to a chiropractor who advised him to see a vascular surgeon. To make a long story short, the vascular surgeon advised him to keep doing exercise. Now, vascular surgeons told him to do exercise because his symptom was only claudication. Remember, vascular surgeons' option is only bypass. Below the knee, they know their bypass grafts do not stay open long. So they will only operate if there's limb-threatening ischemia. So he likes to do exercise. He did not like this pain. He denied any chest discomfort. You always want to rule out coronary disease. Mildly elevated blood pressure, elevated cholesterol. He did not like taking any statin, and he's a vegetarian. So peripheral arterial disease, this was my impression. Rutherford-Becker class 3, ABI is right leg 0.8, 0.49, left leg 1.1, 1.3. Left was normal. On the right, monophasic waveform, hypertension, high cholesterol, pre-diabetic. Got an MRA. You see that on the left side, it's rotating. Would you click the right side? Excuse me. Would you click the right image on the screen? Just click that and it will play. And on the bottom, there's an play button. I'm sorry. I have a mouse. I'm sorry. My apologies. Let me see. So this is why I like MRAs. So I'm going to stop this to show you. So this is his right leg, popliteal artery completely occluded from the proximal area. And let me stop this one. and show you. So now there's venous contamination. So the quality of MRA, if you don't time it properly, you will get venous contamination. So this is all venous contamination, but you can see the SF is nice and clean. On the right side, the popliteal artery, you don't see anything. You start seeing the posterior tibial artery right where it begins. This is the peroneal artery. This is the posterior tibial artery. The anterior tibial artery is thread-like. I don't see much over here. You see right over here, faint anterior tibial artery. So now I can plan the strategy. If I want to come posterior tibial, I know what I'm doing. If I want to come antegrade or contralateral, I know. So this is why I love MRAs. Also, there's no contrast. So brought him in July 2022, below the knee inguinal ligament. You saw the findings. We did kissing balloon angioplasty of the ostium of the posterior tibial peroneal. We use a Hawk-1 atherectomy device for the distal popliteal, TP trunk, and the ostium of the peroneal artery were treated. We used a chocolate balloon, 4 millimeter by 40 for the TP trunk and the distal popliteal artery. And a 5 millimeter 120 chocolate balloon was used for the popliteal. And finally, the popliteal artery was treated with a drug-coated balloon. So this was done in July 2022. Goes home, and this is the result. I'm not going to waste too much time because you have seen enough angiogram. This is the popliteal artery. The TP trunk starts right over here where this is occluded, and this is how the result looks, the TP trunk over here. The anterior tibial comes off somewhere over here, and this is the peroneal ostium. This is the posterior tibial. Only the ostium was involved of these vessels. So I'm very happy. The result is good. He goes home. A year later, he comes back, and he says there was significant improvement when we opened, but now he has started having right calf pain again. If he sits down, it gets better, denies open. Blood pressure was running high. As I said, he didn't like taking medicines. And we did an arterial duplex, the 100% occlusion of the distal right popliteal artery, proximal ATA, TP trunk, and the posterior tibial. ABI is again miserable on the right, left looks good. So now a year out, and we bring him back to the cath lab. So we bring him back to the cath lab. I won't, again, waste time. The only thing different we did this time was I placed a coronary drug-coated stent in the TP trunk because I was afraid it's going to shut down again. And so I said, okay, I will place a rest. I did the same thing what I had done in the past. We put him on aspirin, prasugrel, and a low-dose Xarelto 2.5 milligrams BID, which I'm using pretty, I would say at least 50 to 60% of my patients in PAD. And we did an arterial duplex. We followed him closely. And I said, okay, if you restenoze again, I will have to do something again on you. So a year later, patient comes back, started experiencing claudication again has restenoze. We did an arterial duplex, and it shows 100% occluded right popliteal artery. What are you guys going to do now? Any suggestions what you would do? Anybody? So I was scratching my head. This is the third time, and I was afraid my teacher in Detroit would think I'm just doing this procedure to make money. I just wanted to get rid of this patient. But anyhow, so we brought him back in May of 2024, and we did this again. This time I used a shockwave balloon. Everything else the same, chocolate balloon, atherectomy, everything. And I'm trying different technologies, trying to see which will keep it open. Finally, we used a 6 millimeter balloon, long drug-coated was used in the popliteal artery. Okay. He's doing good. We do arterial duplex in June of this year. We do arterial duplex in September. Boom, we have again a problem. Monophasic waveforms. So I just bring him back in September, and we opened up the artery, distal SFA to popliteal with drug-coated balloon. And this time I used a biodegradable Esprit BTK stent, ostium of the right posterior tibial artery, and we opened up we placed another stent in the ostium of the right peroneal artery, and we treated the popliteal end. Now, what do you think is going on with this pipe? Because at this time, I'm scratching my head. What is going on? And this is where I will tell you, I goofed up. What I didn't do a test, which I would teach you guys to do, and I will start doing it regularly, is to rule out popliteal artery compression. So this is after I did the angiogram, there's a stent here, the biodegradable, there's a coronary stent here, and this is rest. This is with plantar flexion. This is with dorsiflexion. You see what happened to the popliteal? So when I moved his foot up, the tendon or the band from the calf muscles shut down the popliteal completely. And this is again with plantar flexion. It took me less than a minute to get these pictures. If I would have done this, so now I've told myself, anytime I'm treating a popliteal artery disease, I'm going to do this simple test. Make the patient pull the foot up, inject dye. Make the patient put the foot down, inject dye. It is rare. It is not common. This condition is, I've been practicing 30 years, but this is the first time. Maybe I've missed others. It's possible. So popliteal artery entrapment syndrome is a rare vascular condition that affects the legs. It occurs when the popliteal artery, the dominant source of blood supply to the leg below the knee, becomes compressed by a muscle, tendon, or band behind the knee. And just yesterday, the patient underwent surgery where the surgeons went in and they found there was a band and they cut that. And I think that's the problem why he was shutting the vessels below the knee, because when he would walk, his popliteal artery would keep shutting down. And so the first time I didn't put a stent, but he still shut down. Second time I put a coronary stent, he shuts that down. Third time I do shockwave, he shuts down. So the fourth time now, hopefully now with no band. So a lesson learned for me, and I'm just sharing it with you because I'm still learning in my life. Çok teşekkür ederim. Any questions? Otherwise, I think we have very interesting cases to go with.
Okay. Thanks a lot for excellent presentation, Mr. Niazi. And
I think both of our cath labs are ready. Ersan, can you hear us?
Yeah.
Yeah. What have you done so far? Can you summarize the case, please?
Yes, we have taken the last image now. 24'ten. Can you show the images?
Bunu gördüler mi?
This is the last image after the 115 drug coated balloon. Can you? We will start from the 24. We did predilation with 4 and 5 balloons. Afterwards, we did some get some images from the below the knee arteries, and there is no need for balloon dilatation for below the knee arteries. The posterior tibial is intact.
The next one.
The next one. You see now after 5 balloon.
Can you show the other image?
This is the 5 balloon. Can you see the images?
No.
Yeah, this is below the knee. There's a we didn't do any dilatation to this place, and the anterior tibial or posterior tibial. You see, it's approximately intact anterior tibial. The first images before the procedure, we cannot see the anterior tibial artery, but it's intact. The next one, please.
Ersan, is there any connection between arteries?
Yes. In the mid SFA. In mid SFA and in the tibio-peroneal trunk, looks like there's some arteriovenous connection, but we didn't do any predilatation to tibio-peroneal trunk. Maybe the patient has a history of some previous procedures. Maybe they were the fistulas from that procedure. The next one, please.
It doesn't prevent flow.
Yes, it doesn't prevent flow. This we look for the posterior tibial artery. If there's a problem with that, there isn't any problem. The next one, please. And this is the last image after the drug-coated balloon. Do you have any recommendations?
Congratulations, Ersan.
Ersan, the result is acceptable. I want to ask a question about the follow-up period. This patient is 32 years old and he has Berger disease. In the follow-up period, how do you manage the medical treatment?
Yes.
Medical treatment long term. long
Do you
term.
mind giving anticoagulation or just dual antiplatelet?
Diyor silastazol hem dual antiplatelet long term continue.
How long do you use antiplatelet therapy in this patient? 1 month, 3 months, or else?
The dual antiplatelet therapy at 1 month, but there is in the literature not found correctly.
Yes, you are right. In my opinion, it is the 1 month. It is reasonable.
I have a question for you.
Yes.
Professor Arslan, Mustafa, you did great. This is a very difficult case, and you made it look very easy. But one suggestion, this is not atherosclerotic disease, which I think all the other experts also recognize. This is Berger's disease. So definitely abstinence from tobacco is essential. But consider, there have been recent papers that have come out suggesting checking HSCRP. That's an inflammatory marker. If you have inflammation in the body, then giving them low-dose colchicine once a day, 0.5 milligrams, has been shown to be very beneficial in patients with coronary disease and peripheral vascular disease. In fact, when they looked at the benefits of colchicine once a day versus statin, they found colchicine, if given, has more benefit in coronary disease than giving statins. So HSCRP, if it is greater than 2, you should strongly consider giving patients. So this patient with the tobacco use, if his inflammatory marker is elevated, you may want to throw what we call the kitchen sink at him. You know, give him Xarelto low dose, give him clopidogrel, and throw in the colchicine 0.5 milligrams. It's not the gout dose, which is 0.6 milligrams BID. This is a low dose colchicine. Just a suggestion.
Okay. Thank you very much.
Is there any comment from the panel, or we will connect to the other salon? Congratulations, Ersan, and yes.
Thank you.
Thank you.
Thank you.
Evet. Yılmaz Ay.
Hay. Nerede kalmıştık ya?
Nerede kalmıştık?
Geçmişe dönelim biraz.
Geri gel bir daha.
Now, we were not sure about the distal architecture. Then we concluded that biraz daha geri. We were in a collateral artery. Then we have biraz daha geri. Dr. Ahmet has requested distal architecture of the arteries on the foot. As you can see, there is, although it is very late, there's a distal filling of DPA and tibialis posterior artery. If we fail, we can have retrograde micropuncture and continue with that route. Next one. Now, in that image, we see that we are in a parallel collateral artery, not in the tibialis anterior artery. Continue. The next one. Devam edelim. Next one. Burada duralım. We are in the other side of the collaterals, and we have carefully pulled back the balloon backward and have some injections. We see that we are in the trulament at that level. Then we crossed. Bir sonraki. On roadmap. O geri gel. Bu oynasın. On roadmap, we crossed the tibialis anterior artery, as you imagine. Then we had balloon dilatations. Devam. First two points.
Which wire did you cross with the cross lesion?
First, we have Halbert 018. And then we used MG. Then the roadmap you had seen was just V14. Okay. We have balloon dilatations with two balloon and then thereafter five balloons. Now we can have some imaging if you wish. Şu sulu pak bu muydu ya? Bir de alalım olmazsa hem göstermiş olalım ne yaptığımızı. Bir yerimizi görelim.
Böyle biraz yukarıya.
Ha. Ekran daha küçülmüyor değil mi? Tamam böyle dursun. Böyle bir DSA yapalım. İyi misin? DSA. Evet. Test nice. Bir aşağıda görelim. Yine slope'a kalalım.
Basarsanız ben yerini ayarlayayım istersen. Yerini ayarlayayım basarsanız.
Bir aşağı biraz da. Biraz da. Tamam. Az bir şey yukarı.